As all of many of you are students of economics, and even otherwise, any person would think a little bit about it and say, did we always have a possibility of rapid transmission in the country? Is it such a surprise? The COVID stepped up once issues and everything else happened, opening up happened. Now, if we look at data, and what I'm going to do in this particular presentation is, since we are talking about students, I'm going to give you a lot of empirical information about various things. So we'll look at the National Sample Survey data as the NSS conducts surveys on, including health. There have been 4 health rounds. Or to those of you interested in health should look at the NSS health rounds. So the latest health round is for 2017. I wanted to see what kind of disease burden picture would give us some pointers about whether or not we should have been worried about a rapid spread of disease. Now, if we look at this particular chart, on the left side are the OPD cases split by the broad areas of disease, and on the right, that is inpatient, outpatient and inpatient, citus hospitalization. I want to draw your attention to is the blue slice. The blue slice is the biggest slice. The blue slice says that anything that can be communicable or infectious diseases would go into. The infections were 32 BT and 31% for IPT. So these are among people who sought. So for OPD it was the last 15 days. For IPT it was a year. So of all care, what percentage had infectious? It's 32% for OPD. That was a big.
Can I interrupt for a minute? Your PPT is not seen, so we are meeting.
You can't see my PPT?
We are sharing the PPT.
Hang on.
No. But okay, that's okay. We are sharing it. That's not a problem. You just go. You just indicate the screen, the slide, and we'll coordinate with you.
I'm very that you're not. Let me, because if I know how to set the how to just try and do that.
Now we are seeing that pie chart, ma'am, with blue. So we will follow. Present it actually. Screen share it. You go ahead, ma'am.
Okay. Right. So
we will follow
what
screen share.
I was trying to the presence of infectious diseases. So we had the information. So we know that this is good at infectious diseases the same way, whether it's COVID or anything. Now, who among the age group most vulnerable to spread of communicable disease? Switch off the audio. There is a lot of background noise. Thank you. So, if you look at this, look at the bottom two bars. The bottom 2 bars, you have communicable diseases. So the biggest share for adults, 15 to 59, and followed by children, and then by among communicable diseases, the adults who share the maximum space composition, which is in. These are the people who are who are going to be spreading the infection. The point is that while the entry of COVID into the country traced to international travel, once in, there was always a fairly non-negligible probability that the infection behavioral norms of people in our country would be fairly similar for COVID and other infectious diseases. Lack of stem cells, lack of hygiene and sanitation, congested habitat. Mostly adults, as we just saw. Next slide. You will see that while adults are supposed to be the most robust group in terms of resilience, it affects the elderly also the most. This is comprises a major risk transmission. So infections have picked up, and there's a similar picture. Who will be impacted the most? You can see the demand for care increases rapidly with increases in age, and that is the point I'm trying. Demand for care from in rural areas, and that could be because of awareness and other things. It could be by the survey. So this is corroborating the same conclusions. In the next slide, they will spread through adults but impact on the elderly. And all this needs a significant preparedness of the health sector, and we should have disease presence. How would we have done to the health system, etc. Or alternatively, one has to prepare the health system ways to prepare for such pandemics. This is just a case in point that I want. So I think to the point that how to prepare the health system when for pandemics, epidemics, etc. Since pandemics do pose a serious threat to economic and livelihoods, it's imperative to understand how one prepares for it. Population prepare and effectively. Now, so needing a resilient public sector, needing a strong surveillance mechanism, adequate health personnel, sufficient medical supplies and equipment, continuous training. Actually prepared for any of this. Who would do that? Now, many of your economic students should be able to answer this. In fact, pandemics, epidemics, etc., cannot be dealt by private sector. It's such huge calamities, and that public good, as we know, is not provided by the market because of market failure. It is mainly the government which has to put in health system. You cannot depend on the private sector to resilient health system. This is not, we are not talking about only talking about prevention and management. It has more features of a public good than else. And prevention also has a huge feature of externalities. So in the case of public good and so therefore the government has to be the main player of resilient health system to manage outbreaks and epidemics. Now, health systems, according to there are many ways you can, but basically the 6 building blocks: human resources, technologies, health information, health delivery, and governance. Right. So those are the 6 baskets in which we divide the. We discuss each generally. Our health system. All of you are very, very familiar, especially all your teachers are, but it's still good to reiterate. Now, interestingly, there's been a lot of work on who had initiated a joint external evaluation to help countries preparedness of the health system, public health, infectious disease and outbreaks. Now, a wonderful thing if India had actually itself. But when you go to the website, the India report is missing. There are many other countries that have done this kind of done it. Either it's not done it, or it's not completed it, or it has maybe not. Really don't know why. But the point is that an epidemic preparedness index to assess national level preparedness for pandemics for 198 staff there. So you that elaborate health system set up in the country, right? And we were supposed to put up population norms. What maintain what happened? We are looking at this picture. It varies. There are states that are not as badly off. The northeastern states are doing much better as of now. But mostly, this is actually the picture. Next, in the next slide, I also infrastructure talked personnel, but there are significant shortfalls. Reporting civil centers and health and wellness centers are short, PHs short, etc. And in the urban areas, it's even worse. In fact, the urban scenario of the health infrastructure is actually from even I can know from living in Delhi that you've just seen, I don't know if you're reading in the newspaper, that not been paid. They've all been on dharna, wanting their salaries for the last 4 months. So there is something seriously been conducted in our sector, because we are not being able to, so-called warriors are not. So there's a shortfall, personnel and infrastructure, and is actually not optimal. Which next in the next slide, which I say that with shortages of infrastructure, we'll talk about COVID in a bit. But if your public sector is not fulfilling the kind of promises it made, then to see what has actually happened in India. There's this rapid unregulated expansion of the private sector to fill it, because people are going to, they do need, and they will, they're not going to be functional. They go to the, it shows and hospitalization facilities and consultations and charitable trust and NGO, and facilities and consultation. That is where people go, because it may not be affordable, but it's available, and exactly because lived up to their 2 hour expectations. Next slide, we show that happens. Now, there are beds in the government hospitals even without the additional COVID burden. So, study after COVID had actually created so ICU beds, hospital beds, and ventilators across states and union territories, and pains a future. The distribution are very distributed in 7 states. So most of the that you would happen COVID would not be met because it really don't have. So the coming back to this private sector story is that if you do differential in prices, so in to be paying for hospitalization, one hospitalization 4,100, out-of-pocket payment, expenditure per hospitalization is very high, and so it is true of the OPD. To go to next part of the story. So we have seen when COVID hit us that we were very slow to increase. We were not equipped We didn't have enough labs, enough kits. We have been really floundering 2-3 months. In the early stages, we had a shortage of PPE. And other medical supplies, and we had been reading a lot about health workers getting infected. Several months, rapid progress was made, indicating that we could have actually done it. It was not that we didn't have the capacity. Surprise when I was actually reading for a paper I was writing, devices that we get. Mostly on imports. That is 80% of our requirements meeting and anticipated demand. Now, it's very surprising. India is supposed to be technology, etc. Why can't we produce our own medical equipment? Anyway, since the 3-4 months, so my point is that because of shortages of personnel, infrastructure, equipment, COVID care also took a hit at government because many poor people go to government facilities for care. So they also could not go to government facilities. The government facilities were trying to gear up for. Somebody can mute their microphone. There's a sound that is coming.
Mute.
So the thesis is that out in the present that look, a lot of people didn't visit due to lockdown, but many who did want to go, and that's true of us also, private providers, because private providers are available and accessible. You can get risk, take risks. So data is not available as of now. It can only come in a couple of see an increase in private care more than what, and therefore a concomitant increase in out of pocket. There is a whole literature that many of your students are familiar with. Pocket spending leads to catastrophic spending, leads to poverty, which I'm not touching out of pocket spending in this. To the next slide. The question is, the next major part of my talk is that the question India remains unprepared to face a pandemic, minimize the impact on individuals and households. Why has the health sector not been able to respond better? Why equipment, etc.? Why this scenario happened? I think this is a question of prioritizing health sector in the country. There are many other indicators that one can. You remember those 6? Really very, very related to one important control knob, and that is health financing. So when you talk about preparedness, one key ingredient of that remains, because even if you like equipment and medical supplies, pay your warriors, for instance, and get the warriors in place because they are missing mostly, you really finances. Health financing becomes a very knob for prioritizing health. Now, when we do international business, answer that question, that did some countries prioritize, is by looking at how much money they have been putting in the health sector. Now, having said, I'll just briefly touch upon a very interesting point. If you remember the 6 baskets again, they were health governance in the health sector. Now, around the first 5 blocks, including health financing, on much governance. In India, also find very few articles on governance, and mostly the delivery and financing. Now, Niti Aayog had constructed a health index for health index report, and they had three groups of indicators. They had health outcomes, governance, and the governance indicators were very few because they formed the best in the composite, performing as well in the domain of governance. Now, Tamil Nadu has always been shown as an example of better governance, things into account because of lack. One feature of, if you remember, in the initial phases of the pandemic, much better. Now Kerala has not; it has slipped again. Beginning, Kerala was doing much better, and there was a lot of rural governance, which was based on a decentralized model, which was not included in the index. Now, the fact that you had governing structure shouldered a lot of responsibility related to health, sanitation, etc., has said to be shaped the way health system in Kerala functions, and to function much better. And it was said that is one of the reasons some has really come up to speed. And initially it was floundering, but maybe these better governed states are able to show more results. So there is a link between indicators and governance, and I always think that it is necessary. Go to the next slide. That there is a strong correlation between other building blocks and governance. Systems are likely to have all other building blocks. And how can you see this relation? Better governed system and health finance. There is a way one can do that, and students here might be interested in this kind of a graph. So, got the IMR with picture of states, right? Right. If you go, you see that these are the first states basically. So there is Tamil, Kerala, there's Karnataka, etc. Take a vertical line through any of x-axis. Let's say your per capita health expenditures around 1,500. So if you take a 1,500 touches a few states, right? So it is touching Karnataka, it's touching Rajasthan, etc. Similar, but you get different IMR. Kerala and Maharashtra both spent about 2,000. And if you go right up, there's Tripura there. Things are very different. So there is a better governed, are better able to utilize their resources. That is health. So if I go to the next slide, basically I'm saying that health financing is necessary for building a resilient health sector that can withstand the shocks and calamities. But it is a necessary condition, not sufficient. You need good governance as well. Come back. So one common variable that is used, government health expenditure as a percentage of GDP. Now in the vote 5.9, vote 6%. So if you look at other countries, so take countries in this. So they spend about middle income countries to Thailand spends 2.9, right? Least developed countries spend about. Now India is now moved up from the least developed countries in World Bank definition, right? So we are looking, so India's 1% does not really compare well with its own group. You'll see that public GDP for center and states has remained almost static. This is a sure way of prioritization in the health sector. So in 2000, we were spending one. It marginally moved up to 1.4 and 18. And I'm actual numbers. The 18, 19, and 19, 20 are estimates and budget estimates, but then if you finally may actually come down again by 1%, I mean 0.1 or something. So for 20 years, and if you go back, a similar picture. But so we have not done anything. Next slide. If you look at some of the states, right? So government health expenditure for selected states based on RBI percentage of actually GSDP. That should not be gross state domestic product. Now, you were action group states. It's always that we target. Used to call it. These were called the Maru states. That Madhya Pradesh, Rajasthan, Orissa, now Jharkhand, etc. They're all been added. 7, and Assam is also often included. So 7 plus 1, we say, are the vulnerable states. The EAGs spend very little per capita, and they spend very little percentage of GDP at 1.2. But the non-EAG states, the West Bengal and Tamil Nadu and all these things, they don't spend anything worse. There's 0.7% of health expenditure. And Northeastern states are doing much better. So if you look at the actual levels of per capita health expenditure, you actually see that states like Kerala is beyond, below Kerala. Delhi spends much better, but Bihar spends about 5. Give very encouraging picture of being able to they can't deal with current I talk a little bit about the health budgets. As a percentage of GDP over the years, and they have of the GDP is what we have ended up spending health. In the next slide, a similar picture I'm showing for spending. So you've got the point that it is spending better levels, and nor are we spending out of our GDP or GSDP, any which way we look at it, the pitiful picture. In the next, we go up to, this is slightly a different concept. No, so far we will do things. Government expenditure is on education, health, defense, social welfare programs, etc. So is it that out of government, is the health expenditure percentage of health expenditure has a little bit at least? So hardly. I mean, maybe 2.1 to the actuals, and the orange ones are the budget estimates. I mean, it has disappeared, but it hasn't really moved much, so we are not surprised. If the next slide, it is basically summing up what we have seen so far. Continuous low investment in the health sector which has happened over the years, and data is there to substantiate all of that. That's why I was saying investment in the health sector. Result, out of pocket is basically out of pocket spending, financing in the country. Annual health accounts shows that. So this is how the biggest slice is how household out of pocket payments. Households, a complete no-no in any developed that wants to move towards universal health coverage. That is the picture. So just go back to the previous slide. As per the national health accounts, 63% is financed out of pocket. We don't have health coverage for a majority of the population. In many countries that have, let's say, most of the population would be covered by universal health coverage. We have least coverage. I mean, we have very few people who are covered. The people who are best coverage are the government sector employees. So it does spoil its employees. So it gives them a lot of coverage, but the rest of the population can actually depend on the system outside of the coverage. So we are in the group of countries that spend the least out of government. Now, who bears the major brunt of health spending in the country? The federal structure should always be kept in mind. You know that the health is a state subject. And secondly, it is the state government spend much more than the central government. 70% of total health expenditure is incurred by state. So is it true? You can always ask, so ma'am, the central government is not spending. There are enough governments have out of their GSTP, and I just showed you that as well a little while ago. 1% of GDP, you know the states could not be spending much on health. So if you go to the next and the next slide, these enter in the state. Over the years, the share has remained pretty much like this, 63% state center. So the onus of spending falls mostly on the states, which is a very important point to bear in mind in this February. We see the privatization of the health sector is a program which has not fundamentals of the health sector. It has just been a program put on top of them, and it is not, the allocations under actually they have not been sufficient to carry that program, good, bad, or indifferent. If you want to catch A or the HWC allocations, they're very, very low. So overall, the in 1920-21 has been a very we also want to see what allocations for other sectors. So in 2021 budget, the health allocations were 2.2%. 2%. Even education country, and then there are, you can look around the circle and you'll see the total allocations, and health is one of the lowest. As a social sector, it should have seen a huge jump, but it did, even in the current scenario. Next slide. So in sum, we have seen that a pandemic like COVID, so COVID, just take it as an example that can suddenly occur. Now, study risk and through quote unquote insurance for an unanticipated event. Preparing your health sector is also somewhat insurance against such calamities. COVID has hit the economy very hard, whether or not we want to. The economy was doing very bad pre-COVID, pretty badly pre-COVID. Many of us know that. And then COVID happened. Know that there are all kinds of predictions being made, and the COVID very, very hard. So finances would continue to in short supply in an environment of, you can't expect government finances to just suddenly bounce back. GDP in health financing, that policy document promise, or more % of the budget of states. It is not. What should have happened did not really happen, and now in the COVID scenario, it's difficult to emphasize this. So we have years of neglect, I think, infrastructure and service, uneven in the country, agreed. There are some that are doing better than others. Tamil Nadu is an example generally, but if you look at UP and Bihar and Jharkhand and all that, will be a poor. There was a picture of one of the Bell hospital in Bihar, public hospital, and pigs and cows were inside the hospital. That is the way we actually neglect. It did irreparable damage to the health system, to people, because it was improved. The rapid avoid left by the public sector has happened in a regulated environment. There is only one act, clinical establishment, adopted and maintained by states. Very few states adopted it, and implementation is not at all clear what it really means. There is no monitoring that is happening. States may be doing their own bits, but it's not, oversight is not there. So, by the less privileged who have been forced to go to a variety of private providers at high expenses. The next, I just continue to say the same thing, that a country cannot deal effectively with the pandemic by time. That is what India has done. So we have UAE and other countries to send us equipment, etc. over these last but could it not happened earlier? Because why? Because any life that you lose, and we've lost a lot of precious, even one life lost is not, if it can be avoided. In addition to finances, the overall of the system in the country reforms, and India has not done those reforms. Reforms have to happen in medical education, primary health care, infrastructure and personnel, you name it, and it's public health card. Don't really have a public health card. There were some very institutes that were public health institutes, but that term disappeared, because public health is about population health, and people who are when you've seen during the COVID time how we were not doing public health, but was seen as at the forefront. So it's a long list of, now most countries that have a good, robust health took a series of incremental reforms in each of
put a universal health coverage overnight. Universal health coverage system which caters to body with a minimum number of services. You really need these areas first. But what we have done is we have programs without reforms. So if you put a program in place or a scheme in place without for health services, without putting in place your medical personnel, it's not function well. I think it's simple logic that you first have to clean the worst and then cover it with a band-aid. It won't work when you have deep problems in the health sector. And I basically want to, I think that is my last slide, and say that to paint a very dismal picture. All I want to say is that the pandemic is a clarion call for all of us. More focus to the health sector, not to popular schemes and not to schemes that seem really understand what these schemes are all about, but undertake those deep, over that would change the health systems in a next time around when we get another pandemic. You just might, because the world is changing, pathogens are changing, everything is very, just might have another calamity. We are better prepared during the COVID times. Thank you.
Thank you so much for the presentation. Now, students and teachers and other audience, if you over to the floor.
Steven here from third year economics. You spoke the problem of target, and how is that impeding the coming up regarding the
First of all, you're talking about PM specifically, not Ayushman Bharat. Ayushman Bharat is two parts, right? One is the PMJ, Health and Wellness Center. Now, the health and because you're really targeting care, and anything that you do to primary care is always a good thing. But the Prime Minister's Jan Arogya Yojana scheme is now they have a list from this social economic census survey that they have compiled. Clearly not somebody can mute, there's a lot of background noise. Can you just, so what's happening is that the targeting is efficient and it's not really happening the way it should happen, and you have a huge number of people who should be the real beneficiaries. The coverage is still very low, and the fact that the coverage is still very low indicates targeting PMJ machinery, administrative machinery to the mark, and that is not surprising. I really don't blame the people who are doing it, because we have always had problems targeting and identifying the poor in the country. Even the BPL card, as you know, has been so iffy thing because of corruption. A lot of people will produce a BPL card when they are not BPL. And finally, the resources that you need to implement the PMJ, we have calculated for the Finance Commission, are huge. If you are going to be reaching those supposed to reach, that has not happened. So even the last year's allocations under PMJ has gone for not being able to actually do what you had promised to do.
Another question, like about the prevention of these diseases, like the education, like regarding the health and hygiene, which is majority of Indians today. Like having that awareness and education regarding health has increased after to avoid any further diseases like these or spread of those diseases.
Even it's not at all, see, anything that you ask about, time will tell. But the interesting part, awareness was always rather low in the country. Why? Mainly because of education. And states that have had states that are generally more, there are percentage of their population behind education, especially mother's education. So mother and child health has also been a very important thing that has suffered. Education is always going to be an important right-hand side variable in your regression if you're going to do this. However, you can have general campaigns, did massive awareness campaigns through stars and all that. It is, as an economist, you would understand that if you programs for every kind of disease that you conceive, it's going to be very costly. One for polio, then you'll do something for malaria, for dengue. Much better to have to people are able to read, absorb. How many people read English newspaper that they can act at all? So I think that IE's information, education and communication activities are tough to carry out, often don't yield the results that they should have. Now, coming back to your specific, don't think the COVID pandemic has done anything. Maybe for some middle income people they have, because they understand. And you will see the markets opening up. First are not following social norms. I don't know how, because the mask is carried as a jewelry, below that, and people are not actually putting it on their mouths, and they're not social distance at all. So I don't think that is really percolated down to a sense of how to prevent infections, and therefore this graph is actually to come that people who are fighting against each other, not washing hands, not following social distancing, happen. Some people may change their ways, and I hope make a dent in the sticks.
Thank you.
Anyway, welcome.
Ma'am, I'm Amal. I'm happy, ma'am. First one is, India is now the current chair of the WHO, and with considering our past records of these kind of pandemic appointment or being this election as the executive council. And my next question is decentralization and effective decentralization of on the 15th Finance Commission, they made a suggestion on regarding transfer of health as a subject from state to the concurrent list. So how do you view these two developments that are happening in the?
So being on the, it's always a thing to have an important position in the WHO, making a lot of knocks, as you know, with US's around the WHO. So it is not clear. See, WHO has also been, shall I say, effective, very effective in many ways. So whether important position of a chair, co-chair is make India sit up and take notice of what it has done in its own house, I don't have too much hopes from that. No, you don't have to take care of your business in the country. So political thing, and it's a good thing. It gives you visibility. That will translate down into the nitty-gritties, because this is not a very jazzy thing to do. It doesn't bring accolades if you keep quietly see how you can incidents, etc. Those are very grueling admin work. Nobody much better look what I've done for people, because we are in the WHO.
Ma'am, the 15th Finance Committee.
What was
Ma'am,
that?
the 15th Finance Committee.
No, when that is going to happen in now with COVID, it is very difficult to 2 years, frankly, Amal, because whether states are going to be able to defend their low health spending in the face of, remains to be what is happening with the whole GST discussion, etc. States, the flat, they don't have the money. So whether now from moving to concurrent place, I mean that those are not important. Much focus will be given to particular recommendations of the Finance Commission. It could be different, and I hope that it happens. But right now, we are in a completely fighting mode, and we are in countries in distress, states are in distress. So it's really back to basics, and then layers will start taking place. Welcome. Any other questions? So I should just thank everybody for,
Yes, Dr. Indrani.
for all the pictures.
Praveen, are you there? Yes.
Good afternoon, all. It's a long weekend, and I don't want to trouble with spoiler resolution now. So please tolerate me for the Department of Economics. I take this opportunity and indirectly contributed to this webinar on how prepared is India's health sector. A deep sense of appreciation for Dr. Indrani Gupta for her work. Thanks for blessing us with her presence and enlightening us. And thank you for the engaging session, ma'am. I also wish to extend Dr. P. Wilson for his encouragement and support. I thank our HO, Dr. Jacqueline Rajabai, for giving the opportunity. A special thanks to the organizing committee, our teachers, and I thank everyone for your presence and patience today.
And thank you very much from my side, and have a happy weekend ahead.
Yeah.
Thank you so much,
Adding,
ma'am.
adding, can I, madam?
Thank you. Thank you.
Yes.
Hello, madam.
Yes,
Madam, from the economics, I would like to say a very big thanks to you. Very happy that you have given your valuable time, your preparation. It makes us awestruck. Also, I want to revising the dates, and that was because of it is that the college wanted us to follow to conducting the webinar. So I hope you have adjusted with them, joining us in the future. for more lectures. Future also, and say a very big of thanks. Thank you.
Thank you. Thank you, Jacqueline.
Yeah.
Thank you
Very
friends.
much. Thank you.
Thank you, friends. Have a long weekend.
Thank
We
you.
part now.
Ma'am,
you.
thank you so much
you.
once again. Looking forward to meet you personally. You're most
Thanks a lot.
welcome
Thank
into
you,
our
all of
college.
you.
Yeah,
So sometime
absolutely.
later, you should come and present. And
Absolutely. Forward to coming in person and visiting. Thank
yeah, thank you, ma'am. Thank you.
Thank you. Thank
All
you.
right. Thanks a lot.
Ma'am, I'll be in touch with you. I'll talk to you. What, ma'am? Wholeheartedly.